Very very good afternoon to you all. Welcome to the Palliative Medicine session 2. This is going to be kind of interactive session, and it's going to be, in some cases, a case-based discussion. So let's make a start. We'll start with the patient autonomy. That's going to be by Dr. Junaid Patel. Dr. Junaid Patel is a consultant in internal medicine at the Indus Hospital in Karachi, Pakistan. Over to Dr. Junaid Patel.
Assalamu alaikum everyone. My name is Mohammed Junaid Patel. I work as an internist with Indus Health Network Karachi campus. Appreciate and I'm really honored to be invited as a speaker by administration of this conference. So thank you very much. We're going to talk about patients' autonomy today. Autonomy is one of the 4 pillars of medical ethics. It means that a patient has the ultimate decision-making responsibility for their own treatment. It also means that treatment of an individual. It is important because we need to make sure that the patient is actively involved in their diagnosis and treatment. He or she should have the reins of the horse or drive the car or fly the plane, whatever you call it. Individual perceived autonomy has been shown to be related to 3 general components of it. It enhances their life satisfaction, increases positive effect like happiness, and protects from negative effects such as depressiveness. When analyzing end-of-life practices, 4 main stakeholders can be identified. The patient. Patient-centeredness is in the center. Directly interacting with the healthcare team and the relational environment. That is the family, friends, and the communities. Moreover, there is a significant interplay between the healthcare professionals and the relational environment, which will eventually affect the patient. How to do justice to patients' autonomy in palliative medicine? Well, the principle of autonomy places a responsibility on the doctor to ensure that he or she, the patient, is fully informed. Open, honest communication with patients about diagnosis, their prognosis, to enable patients' decision-making in order to grant patients as much autonomy as possible. It is important to support them in a professional manner with good communication skills and maybe tools like Spikes may help. The Spikes model was coined in 2000 by Bale for Breaking Bad News. Set up perception, invitation, knowledge, motion, strategize. So let's take an example of this 70-year-old female who had a hepatic and bone mets of an unknown primary. She was referred to our palliative outpatient department for abdominal distension due to ascites. After palliative radiotherapy of her bone mets for supportive pain treatment a year ago, further oncological therapy was neither planned nor possible. The development of ascites was profound and highly symptomatic. Paracentesis was indicated. After detailed counseling of the procedure, patient declined any invasive procedure. The decision of the patient had to be respected and new strategies had to be taken into consideration. Conservative strategy was established with oral administration of diuretics. This was accompanied by optimization of supportive therapy with antiemetics and analgesics. So with these 4 models in mind, our case is applicable to 3 of these models. We told her that paracentesis would be the best option from our point of view, which is deliberative. She decided otherwise and rejected the intervention information. We clarified her needs and presented her new options via conservative procedure interpreted. She accepted and retained her autonomy and with it full control of her own life. How do they perceive autonomy? Patients feel in control. It encourages their self-esteem. It makes them feel dignified and important. It safeguards the right to make their own decisions. Now, maintaining autonomy is not only a concern of making choices and decisions about the treatment and care, but that emphasis should be also placed on supporting the patients in their daily activities, contribution to others, and active preparation for dying. From the patient's perspective, changes of the body emerging due to physical symptoms like pain, dyspnea, weight loss, and the progression of the disease can be difficult to accept. Good management of current symptoms, as well as the future development of the dying itself, was mentioned in most studies as one of the most important concerns. The need for human touch is pointed out in some studies as something important that is lost and missed due to progression of the disease. Another important aspect of this domain is physical strength, the perception of having enough energy or strength to do everyday activities, or on the contrary, experiencing the lack of energy plays an important role in the perception of dependence. So the patient's autonomy always should be respected, even if it is absolutely contrary. The decision is contrary to the best medical advice and what the physician wants. Thank you very much.
Right. Although I introduced myself in the first session, I'll reintroduce myself. I'm Atif Saleem, one of the palliative medicine consultant from Shaukat Khanum Hospital, Peshawar. And I've got with me Dr. Kashif Sajjad, who is also the palliative medicine consultant from Shaukat Khanum, Peshawar. He was also chairing this session. So we had the talk by Dr. Junaid Patel on patient's autonomy. We can take questions now, if there are any, or at the end of session. Any question if you have? Is Dr. Junaid Patel online? He's online. Okay. So I have a question from Dr. Junaid Patel. So we do know a lot about patient's autonomy. So have you come across family autonomy? What do you think about family autonomy? Dr. Junaid, can you hear us?
Me now? Yes, I can hear you. Your question also. Can you hear me?
Yes, we can.
Patient autonomy की तो हम बात करते हैं, लेकिन of course that goes hand in hand. अगर कोई major discrepancy ना हो, and we try to get to a page or the reach a point जहाँ पे we are all on the same page. So that is a win-win situation for us. And अगर conflicts आते हैं तो फिर of course depending on कि कौन कितना with it है, of course we have to lean more towards the the patient autonomy first. So I hope I answered your question.
So yes, family autonomy, patient autonomy comes first, and
yes.
Sometimes the place where we are working, we are from the East, so we cannot forget. Yes. So we have to take their opinions and respect. So I agree. Yeah, thank you, Dr. Junaid. We'll move on to the next talk. That's going to be by Dr. Rida Mansoor. I was asked after the first session, who's the first palliative medicine fellow. So here we have got Dr. Rida Mansoor, who is the first palliative medicine fellow from Shaukat Khanum, Lahore. Over to Dr. Rida Mansoor. She is going to talk on malignant bowel obstruction. Thank you.
Assalamu alaikum. Thank you, Dr. Atif, for the introduction. So, as Dr. said, I am Dr. Rida Mansoor, working as a fellow in palliative medicine at Shaukat Khanum. Today, I am going to discuss a couple of cases that we face in our daily routine. And in those cases, what we have to do according to the need or the clinical presentation of the patient depends according to the progression of the disease. So here I will show you a couple of cases and then we'll discuss that what do you think that the goal of treatment or the line of treatment should be. So starting with that, there's a case of a 39-year-old female who had abdominal perineal resection and chemo and XRT for a mucinous adenocarcinoma, which was a tumor T3N2 tumor. And the procedure took back 2 years back. The patient was fine for 1 year on and off presentation with lower abdominal pain and some signs of obstruction, but it was managed conservatively. Then ultimately the patient presented with the signs of obstruction. She underwent an emergency laparotomy and loop ileostomy was done for subacute intestinal obstruction. At that time, the patient also had obstructive uropathy because of the tumor. So right PCN was also done at that time. Cystoscopy and TURBT of the rectal adenocarcinoma was done. Patient remained fine for 1 year with the similar on and off complaints of lower abdominal pain, which was managed by analgesia. The patient also presented multiple times in ER with the obstructive symptoms, which were managed conservatively. During that period of time, the patient also undergone some imaging, which showed omentoperitoneal diseases and multi-level obstruction. But in all those presentations, patient was managed conservatively. So in the last presentation, which patient presents in ER with the history of vomiting for 7 days and constipation of 2 days, keeping in mind the ECOG was 3 of the patient. As I mentioned earlier, that during her last visits, she undergone imaging and which showed omentoperitoneal disease with multi-level small bowel obstruction. On examination, the patient was tachycardic with a pulse of 110 beats per minute, BP of 100/60. Abdominal examination, the abdomen was distended with mild generalized tenderness, and there were multiple palpable nodules on the anterior abdominal wall. Rest of the examination was unremarkable. Investigations were almost within the normal ranges. The patient has no electrolyte imbalance or signs of infection. This was the chest X-ray. So anyone from the audience would like to comment on this X-ray, or anyone from the residents? Anyone else? So as pointed out by Dr. Vanya, that the patient has multiple air fluid levels at the level of a small bowel. We can appreciate the right PCN as well as that a urinary catheter can be seen. And so we can appreciate that the 2 stoma bags, both in the left and the right, because as I mentioned earlier in the history, that the patient had APR in first place. So the left stoma was of that procedure, and then ileostomy for the second procedure. So how will you proceed after listening to the history and this X-ray? How will you proceed with the patient? So is there any role of cross-sectional imaging after listening to the history and in this presentation with this X-ray? Will you?
operate on the patient or do any surgical intervention. If it is not the case, then cross-sectional imaging won't add anything further to the management.
Thank you, Dr. Nisma. Perfect. As mentioned in the history, that patient already had mentoperitoneal disease and multi-level obstruction. If even we go for the CT scan, it will not add anything in our management plan. So in this patient, there is no role of cross-sectional imaging. Regarding the conservative management, you people saw subacute intestinal bowel obstruction. So what do you know about the conservative management of the patient? Anyone from? Anyone?
Come on, this is an interactive section. We just want to hear from the audience as well. This is not an exam.
So the management is usually based on IV fluids, NPO, and NGT decompression of the abdomen.
Okay. Okay. Anyone else want to add anything else regarding the medical management or anything?
So despite the drip and suck method by NGT, we can add, we'll obviously add analgesia, and steroids and octreotide also have a role in the management.
Very good. So as highlighted by Dr. Vani and Dr. Mosma, so broadly we classify into non-pharmacological management and pharmacological management. Non-pharmacological management will include NGT decompression and the blood testing, making the patient NPO as she is having vomiting. And in medical management, we start with the analgesia if the patient is having pain, antiemetics, and the role of steroids. And then if we have to proceed further, then there's a role of octreotide in the management of small bowel obstruction. Role of surgery versus stenting. Do you people think that is there any role of surgery in this patient at this moment of time, in this presentation? If yes, why? If no, why?
Lot as well.
It's just about your opinion. What do you think that if surgery or stenting is going to benefit this patient?
No, I don't think surgery have any role in, particularly in this patient.
Any reason that why surgery is not going to have any role in this patient?
Well, the patient has an advanced disease already, and I don't think that the patient is in a status where he can undergo surgery.
So very well said that the patient is having a advanced disease with omentoperitoneal involvement. So surgery is not going to help out with the patient. Is there any role of stenting in this patient? And endoscopic stenting, colonic stenting. Why? Very good. Any other point? Keeping in mind this X-ray. One is the multi-level obstruction. Okay. If this will be a single level obstruction in the small bowel, will you go for stenting?
We can't really go into small bowel. So we can just see up duodenum.
Okay. So one of the limitation in this case would be that the level is at the obstruction is level at the level of the small bowel. So it would not be possible that the scope could go at that point and then we can relieve the obstruction. But in this case, the patient has having multi-level obstruction and so will not go for the stenting. So this patient was managed conservatively with these steroids, but the patient is having very high NG output despite of starting steroids. So we have to shift the patient on octreotide. The patient responded well to octreotide. We were successful in reducing the NGT output, but it didn't relieve the obstruction of the patient. She was not passing anything from the stoma. So is there any role of venting PAG in this patient?
So venting a peg does have a role in patients, but if there is ascites, then we could not go for venting.
Good. So as the patient has omentoperitoneal disease, the patient does have ascites. So venting peg was not an option in this patient. So ultimately we have to, we did multiple family meetings with the patient in presence of a husband and the family members. And then we counsel them for venting NG. So in venting NG, we counsel them that the patient will have to need frequent bouts of small meals, and then the patient will clamp the NG at the time of the feeding. And when the patient will have the feeling of nausea, or if she feels that she is about to throw, then he will unclamp the NG and all the food contents will come out through the NG. So the patient was discharged on venting NG. The patient survived for 2 more months and she was with venting NG. She wants to go home because she had 2 younger kids. So she wants to spend the rest of the life which she had left with the kids. And ultimately then she presented with an acute intracranial event, and then ultimately the patient expired. Aspiration and acute intracranial event, and then the patient expired. So we managed the patient conservatively and best supportive care was given to the patient. In this scenario number 2, we have a 25-year-old male with low rectal carcinoma, which is poorly differentiated adenocarcinoma with signet cells. Keeping in view the ECOG status, which was quite well, it was 1. Patient had a defunctioning colostomy 1 year back, and in that laparoscopic finding were that the patient had a hard mass which was fixed and it was irresectable. So defunctioning colostomy was done, and then the patient was started on palliative chemotherapy. The last he received the therapy was 2 weeks back, and then during this course of event, he presented multiple times in ER with multiple episodes of obstruction at the level of stoma, which were managed conservatively. Now he presented with 2 days complaint of absolute constipation, progressive abdominal distension, and multiple episodes of vomiting. A CT was done, and then this in the CT we found that the patient had obstruction at the level of the stoma. Can I ask Dr. Wahid to please elaborate?
So I think on the axial images, you can see on the axial images, you can see the large bowel is dilated massively with the cecum is probably around 7 to 8 centimeters. And the obstruction is at the level of the stoma, which was done 1 year back, if I'm not wrong. This is the main tumor that is causing the obstruction. So this looks like, and the small bowel, I don't see the small bowel, but I think looks like this is a closed loop, large bowel malignant obstruction with all dilated cecum, ascending colon, transverse colon, descending, everything is dilated right at the level of the stoma.
Thank you, Dr. Wahid. So the CT showed larval obstruction at the level of stoma, as elaborated by Dr. Wahid. So what will be the further management plan in this patient? We have discussed in the previous case that we have the medical management, which is conservatively. We have option of surgery. We have the option of endoscopic stenting. So what do you think? What would be our approach in this patient, keeping in mind he is young, 24-year-old male with an ECOG of 1? What would be your approach?
I believe we should explore any surgical option, keeping in view he has got an ECOG of 1 and young patient. So a surgical approach.
Very nice. Can you point out why, with regard to CT, that why should we proceed for the surgical option?
So the obstruction is at the level of stoma, and he has had repeated obstructions at this level. So I guess a surgical opinion would benefit greatly.
Okay. Dr. Vanya, you would like to add? You are going for stenting. what your reason for that?
So I think stenting through the colostomy would help.
Okay, so we have two opinions here. One is saying that we should go for the surgical opinion. The other is saying we should go for stenting. So this examination finding on this patient was that the stoma was stenosed by the tumor, and even the little finger was not able to go into the stoma. So stenting was excluded on that reason, because the scope cannot pass through that stenosed tumor through the stoma. And then patient underwent proximal colostomy of distal transverse colon. The patient remained well for 24 hours, and then he tolerated well. He passed this stool through that colostomy, and then he was discharged the next day. After 20 days, patient came in again with left lower limb swelling, and on investigation, it turned out that he developed DVT. He received further 2 cycles of chemo. Overall survival after second palliative stoma was 7 weeks. My question here is that, was it worth it to go for that second stoma surgery, or anything which could be done differently in order to improve the survival of the patient or to maintain the quality of life of the patient? Okay. All right.
But the question, was it worth it? I think yes, definitely it was.
Sorry?
The question, was it worth it? I believe yes, definitely it was.
It was.
Yeah.
Dr. Atif, Dr. Kashif, do you think that it was worth it to go for that second surgery?
I think patient was quite young. Most importantly, we should have explored the patient's wishes, and obviously keeping family on board. He was young, so fair enough to give him a chance. My opinion would be.
So what if we would not have operated in the first instance? He would have died straight away with perforation. So I think this was the right choice.
Thank you, everyone. So our intention was that with a collaborative decision with the surgery team, that patient was young. He has an ECOG of 1. So we went for surgery. We saw here that he received further 2 cycles of chemo. So whether, what do you think that what will, if that were not given, would that make any difference?
Sorry, do we have any oncologists in the audience?
No.
We're all physicians, biased opinion.
So, yes, sir. So Dr. White, do you think that patient should receive the chemo?
So this chap is young, and he already had a defunctioning colostomy as a palliative procedure, and he had received already so many cycles of palliative chemo to begin with. Now this time when he came in, I think the decision was right. That this got closed loop obstruction. If you don't treat it, he perforates and dies with the sepsis. So you have to treat it, because the function class is good. He was walking, talking, eating, making fine, I think beforehand when he presented. Which is the reason we did the proximal colostomy, because this was so we did not do any fancy procedure. This was a small cut directly onto the stoma site, presumed stoma site, because he had palpable large bowel loops. So he did not, we did not do any laparotomy. So I thought, because if I do any fancy procedure, he's not going to make it. So just do a colostomy so that he goes home, he eats and drinks fine, and his primary is already irresectable, and I don't think so. Okay, chemo would add on to any survival benefit. So it would have been better if he was not given these 2 cycles. Probably his 7-week survival might have prolonged to maybe 3 months, maybe or more.
Want to add something? You want to add something?
Since the patient was in a palliative setting from the get-go, we've seen patients with similar situation, and with the palliative chemotherapy, they live up to, you can say, maybe even a year or 2. So if we were going full blown aggressive for this patient to give him, best options, I think chemo was a good option in that case.
Okay, so we have two different opinions, but in this case, the patient has already received quite, as I remember, he had received 2 to 3 lines of chemo and he had not responded on that. The disease was progressive. So in that context, we were asking that, was that a right decision? So.
Just want to add one thing. So sometimes the chemo is given in palliative settings for symptom relief. So we need to keep that in mind. Okay. So, so it's not that palliative chemo having 3-4 attempts, failed attempts, and then cannot have further chemotherapy. So if it's going to relieve the symptoms, then yes, oncology team does try. Although I'm a palliative care consultant, but I think this is what I know from the previous experiences. Okay, thank you.
So the last scenario was a 60-year-old female who was diabetic, hypertensive, severe with no residual disease. She has been extensively investigated for cause of cirrhosis and then labeled as cryptogenic cirrhosis and portal hypertension. She had poorly differentiated squamous cell carcinoma cervix and had underwent total abdominal hysterectomy and bilateral self-angioophorectomy done outside hospital 2 years back. When she was enrolled in Shaukat Khanum, her case was discussed in MDT. At that time, the MRI showed no residual disease and it was just the post-surgical changes. So she was put on surveillance and then after 6 months, she presented with the lower abdominal pain and pervaginal bleed. At that time, she underwent imaging and which revealed that she had a recurrence at the vaginal wall along with enlarged pelvic side lymph nodes, which was also causing obstructive uropathy on the same side. Patient underwent nephrostomy for that obstructive uropathy 6 months back. She presented on and off of PV bleeding and she got radiated for the symptom relief of her vaginal bleeds 5 months back. Now she presented in ER with fecal discharge by vagina, absolute constipation, and fresh rectal bleed along with lower abdominal pain. She was GI team. She was investigated. GI team was taken on board for rectal bleed. So the plan was GI team was to go for flexible sigmoidoscopy to look for the cause of PR bleed as well as to look for any other symptoms, which she is saying that she was having difficulty in passing stool through through the anal canal and it was passing through vagina. So flexible sigmoidoscopy revealed external compression by the tumor at 22 centimeters from the anal verge, beyond which guide wire could not be passed. So again, Dr. Wahid.
So I think this is the MRI of the same patient that we are talking about. So you could see the tumor that is basically externally compressing or probably involving the part of the sigmoid bar loops. These are the coronal images. And if you look closely, this is the main bulk of the tumor extending here as well. That's the bowel loop probably involved. And if you see, where the pointer is, there are air specs which suggest there might be some communication. But clinically, this, when she's presenting with fecal discharge from the vagina, it's actually, there is a fistula. All you have to see is basically prove it by the imaging.
So according to the sigmoidoscopy finding and MRI finding, it was proven that the patient was having obstructive symptom as well as the patient is having fistula. So the plan was to go for stenting to relieve the obstructive symptoms as well as to bypass that fistula in order to prevent recurrent infections. So the GI team colonic stenting attempted twice on 2 regular intervals. When they go in, the stenting failed. Then the procedure was abandoned. The patient was given a rest of 24 hours, and then again the GI team proceed for stenting. The second time they also failed for colonic stenting. In this case, I want to ask, should we attempt the third time?
I would say no. Perhaps we look at the other options.
what other options?
So, for example, exploring the option of palliative radiation.
So we do took radiation oncology on board, but they said because the patient is having an ECOG of 3, plus the patient is having ascites and portal hypertension due to cryptogenic ascites, keeping in view the comobs and the functional status, they said the patient should be for best supportive care rather than any other radiation treatment.
So I think you're stuck with the pharmacological management of the bowel obstruction.
Yes. So we as we discussed in the first case, that we manage the patient conservatively with decompression and steroids. So in this patient, we were able to resume the bowel movements after starting the trial of steroids and suppositories and everything. So the patient remained well for 1.5 months, and then ultimately she expired. So these were the 3 cases which we would like we discussed. And in all 3 cases, the diagnosis was same, but the management was different according to the functional status of the patient, according to the disease progression, according to various circumstances to which the patient was and sign and symptom with which the patient was presenting. So this was all for the presentation. If anyone has any questions, please.
I wanted to ask you a question. How convinced we are regarding the role of steroids in malignant bowel obstruction?
If we go according to evidence-based, so we have a weak evidence of effect, according to Cochrane. So, but in our patient, we do see that if we go by percentages, so we have approximately 80% of the patient which do respond after starting steroids with PK.
Thank you very much, Dr. Rida Mansoor.
Thank you.
We'll move on to our next talk. This would be by Dr. Junaid Patel from Indus Hospital. He's the consultant in internal medicine. He's going to talk on bereavement.
My name is Mohammad Junaid Patel. I'm with Indus Network, Karachi campus. I'm an internist and really appreciate and honored that the administration of this conference has asked me to be one of the speakers. We are going to talk about bereavement today. It is estimated for every 1 person who dies, 5 close family members or friends are left behind. Anyone who is involved in delivering palliative care comes across considerable grief reactions of loved ones. In palliative care, clinicians deal with multiple grief reactions: grief over a dismal diagnosis and grief over loss of function or mobility or being dependent on others. When grief is because of the death of a loved one, then it is termed as bereavement. For this discussion, grief and bereavement will be used interchangeably. Generally, there are 5 stages of grief: denial, anger, bargaining, depression, and acceptance. In palliative care, when dying is recognized long before death occurs, denial and anger may occur at the time when diagnosis or prognosis is given. It is important for a clinician to recognize and anticipate the stage of grief in a caregiver, and every measure of empathy should be taken at the time of disclosing the diagnosis. During this acute stage, one may feel strong, empowering feelings of anguish and pain that are hard to contain. Since mostly news is broken in a clinic or a hospital setting, care must be taken to provide privacy for processing of information. In our practice, we have experienced that after deliverance of bad news, an extended period of pause or silence remains the best strategy. This way, the clinician provides time to the caregiver to process and react. Clinician must exercise empathy from every fiber of being when delivering such news, all the while maintaining his or her composure. As the caregivers deal with pain of losing someone, they look upon the people who were closest to the deceased at the time of their death. At times, this person may be the clinician. This was especially the case during COVID, when patients were isolated from family members and the only person closest to them was a healthcare professional. Many times, loved ones asked the last words of the deceased, how they looked, were they pain-free and peaceful in their last moments? For the caregiver, this is extremely significant information. And what we don't think about is how it's impact their coping mechanism. Palliative care not only addresses the needs of patient, but also of the caregivers. Their mental health, social welfare of the whole family, it is all important and holistic approach to the palliation. In early weeks of bereavement, mental disorganization manifesting as confusion, emotional turmoil, poor concentration, state of depression, lack of interest in daily activities is common. People with different coping mechanisms, stages of bereavement may be short or prolonged, but it is universally accepted fact that one never gets over it but just used to it. Family dynamics and one's social circle plays a great deal in providing coping strategies. However, in our healthcare setup, social welfare is close to non-existent. And so it's solely on the individual to move forward and to find that strength to carry on above and beyond. In the Western world, privileges like group therapy or counseling, art therapy, social visit by welfare department can help manage this process. Our social or healthcare infrastructure does not provide that privilege to any patient population. And so it comes down to clinicians to recognize early signs of depression and make a differentiation between normal grief and depression that can have long-lasting, profound effect on the person's well-being. To celebrate memory of a loved one must be encouraged. Part of surviving the pain is to accept it and to learn to live with the loss. Funeral and death anniversaries provide a conduit to battle the grief and come to terms with reality. The period of bereavement can last for weeks to months, but generally 6 months is considered to be the time when most people come to terms with fate. Period extending beyond 6 months may be an indicator of other psychiatric illnesses like major depression or prolonged grief and require for a formal psychiatric evaluation. Remember, it is not easy and there's no one fix to it, but we can always walk this path of life together. Thank you.
Thank you, Dr. Junaid Patel. If we have any questions from the audience. So, right, so we moved from patient's autonomy to malignant bowel obstruction. We talked about quality of care, providing quality care to patients. Then we talked about bereavement. So mind you that palliative care, palliative medicine doesn't end when the patient dies. So we keep in mind that we have to extend our support to patients after death, patients' families after death. So now we'll move on to the next talk. This will be by Dr. Rida Mansoor. It's going to be on hematological malignancies. Thank you.
Assalamualaikum again. So in this presentation, I would like to discuss with you and wants to have your opinion regarding regarding an ethical issue, which usually we face in hematological malignancies. In our part of the world, as Dr. Atif said, that we are from East, the influence of family in our setup is very much. So we do have to look into the matters of the family. We have to respect the decision of the family in terms of patient management and care. So our population usually don't give up as easy. They don't want to let the patient go. They want to try each and every option till the time comes when the patient leaves. But they want to do each and everything which is possible, which is humanly possible on the earth. So we are starting with a question that, is it cruel or kind? Keeping in mind this scenario, a 56-year-old female, metastatic breast carcinoma with bony metastasis. Her status was post-chemotherapy, radiation, and surgery. She was on hormonal treatment. She presented to her oncologist with just the complaint of generalized weakness. Her oncologist get a complete blood picture, which found to have pancytopenia on the blood with HbO 6.5, white count of 2.2, and platelets of 45. What will be the next step? If this patient presented to you, how will you proceed with further investigation? Yes. Thank you, Dr. Seemal. Anyone else would like to add something?
So for those who couldn't hear, one of the audiences mentioned that we would do further investigations in order to look for the cause of the pancytopenia. So that would include some blood investigations like peripheral smear, checking the B12 folate. So any other option that we could consider? So someone mentioned bone marrow biopsy. Okay. Right.
So we did extensive blood work, as Dr. Seemal said, but we didn't find any cause for the pancytopenia. Ultimately, it was decided to go for bone marrow biopsy. After transfusing the patient, because she is having an HbO of 6, so for the procedure, we have to transfuse, make her comfortable with all the settings, and then bone marrow biopsy was done, which showed marrow involvement by cancer. Now we have the diagnosis. How will we convey this to the patient?
Do you think the bone marrow biopsy was appropriate?
Yes, according to that sample taken and what they said, that bone marrow, the sample was adequate, and then they mentioned, sorry.
The question is, that was this the right thing to do?
After doing all the this was the decision of a hematologist, that if all the blood labs were normal, so they want to proceed with the bone marrow biopsy.
So bone marrow biopsy was actually done to rule out the reversibles. So we still have to consider, even in palliative settings, the reversible causes of this bone marrow suppression. So that was the reason we had to go for the bone marrow biopsy.
What is your opinion?
Someone with the metastatic disease with a bony mets, the likely cause would be the bone marrow infiltration by the malignancy. So, it really depends on the ECOG and the functional status of the patient and the quality of life. I'd put it across to the patient, discuss it with them, give them the likely possible options, and perhaps I'd just palliate them with the transfusional support if that. But that's, difference of opinion. That's how medicine works.
Yes. So this was done before the patient was referred to medicine. This all was done when she was in the oncology. So family meeting was conducted by the primary oncologist, and then detailed counseling and breaking the bad news was done from the primary oncologist to the patient and as well as to the family members. We talked about patient autonomy, but in this case, the patient stated that I don't want to involve in any of the discussion regarding my goal of treatment. I don't want to hear anything about the stage of my disease. I want to nominate my son for every decision to be made regarding my goal of treatment, and anything to be done with me should be discussed with my son. So son was the primary caretaker. He was explained about the disease and it was told to him that now the patient is having bone marrow infiltration, and it was proven by the bone marrow biopsy. So, and we will transfuse only in case of emergency or if there or if need arises. Son continued to get labs done from outside Shaukat Khanum, and he was giving transfusion to her mother, irrespective, just on the numbers. The patient was not having any symptoms, but he gets the CBC done. If it is less than 10, he just transfuse her mother. Ultimately, patient presented to us with the complaints of burning, micturition, and fever. And on investigation, it turned out that patient was having urinary tract infection leading to sepsis. She was being managed on the line of sepsis. CBC also showed hemoglobin of 6 with a platelet of 40. But patient was not actively bleeding from any site. Even in urine analysis, there was not any microscopic hematuria as well. I want to ask the audience, what should be the threshold of transfusion in palliative patients regarding HB and regarding platelets? So here's a question, and here are some options.
Go for the transfusion. Otherwise, there is no need to.
Any number you are saying that if the patient is symptomatic, irrespective the patient is having HB of 5, will not transfuse the patient?
Yeah, I would say so.
Okay. Thank you, Raksima. Anyone else?
Patients who come up with the HB less than 8, we usually transfuse them and provide them through transfusion support in palliative.
To agree with what the audience has mentioned, I would go with if she's symptomatic. So there is, absolutely no cutoff for these patients. You're basically palliating their symptoms, ensuring they have some quality towards the end of their terminal disease. And you might be increasing their disease burden or, increasing their misery by transfusing them.
So in palliative medicine, we talk about quality. So it's not the numbers. Again, I'll keep on emphasizing it's not the quantity or the numbers, it's the quality. So if the quality is effective, then we would transfuse, otherwise no.
So we have a consensus that if the patient will be symptomatic, just to improve the symptoms of the patient, we will transfuse, we will not go by the numbers. Indication for same for the platelet transfusion, that if the patient is having symptoms of bleed or patient is bleeding from any side, then we will transfuse. But in this case, it was decided to transfuse red blood cells, but not to transfuse platelet, since she has no evidence of bleeding from any side. Son did agree with the decision. Wanted platelets to be transfused as well. It was explained about that there is no indication or emergency to transfuse platelets, but he was the opinion that we should transfuse platelets so that so the situation might not arise of emergency. So he wants to get the platelet transfusion done as prophylaxis. Multiple meetings with the family were held in the presence of hematologists, oncologists, palliative team, explaining about the futility of ongoing transfusion, as Dr. Kashif mentioned, that we are just increasing the agony and the disease burden. We are not treating or we are not maintaining a quality life. But family requested for time to arrive to a decision. Meanwhile, it was decided that we will transfuse if the attendants will provide the donors, and will continue to transfuse till the family gets to a decision. As expected, son exhausted all his donor resources. He now expected the hospital blood bank to provide the blood products and to help with the ongoing transfusions. when to stop transfusion if the family doesn't agree.
Sorry, can you hear me? So I think the bigger issue seems to be the son here, who is definitely not acting in the best interest of the patient, and he needs counseling and psychological support perhaps. Did someone had a word with him? Did someone had a session with him? Did we arrange some support for him? Because he definitely doesn't seem to understand the gravity of the situation.
Multiple sessions with the psychologist were arranged. He was counseled extensively by the primary oncologist. We took a second opinion from a hematologist. We get psychological counseling from three different psychologists. We have multiple sessions, but he was not able to understand. He was not understanding the situation that transfusion is not helping her mother. It's just increasing the disease and the agony of the patient. So by stopping transfusions in these type of patients, are we doing a cruel thing or a kind?
I would say that you're helping the patient. It'd be kinder to not to give her further blood products.
And even for the audience, a different opinion.
So where there is a need to be cruel, can't we? Where there is a need to be cruel as a healthcare professional, can't be anytime cruel. We are all the time kind, but what if we say this is not the policy? But what if we say this can't be?
Yes, so I think we as physicians, the responsibility lies in our hands. So patients can ask for the treatment, but it's down to us whether we want to provide this treatment or not, and whether it's in the best interest of the patient. So they cannot demand the treatment. Obviously, they have a right to discuss. It seems that son had taken that responsibility on patient's behalf. So it will be down to the treating physician, but obviously it gets very difficult when family is not on board and they are not in agreement.
Would you like to add something?
So it is indeed a difficult decision. So it's not easy, but yes, so we have to at one stage make a decision to stop the transfusion. Someone would come with a question, yes, it is cruel. So we have to sit with that person in particular and address the concerns. And so it's like breaking the ice. So it can't be, you need to see what they are expecting, what their concerns are, and what their ideas are.
So usually we see patient and the attendants just had that consult कि अगर हम रोक देंगे खून देना, the patient will ultimately expire. They usually say that कि हम खून आप चाहते हैं हम उनको खून देना बंद कर दें और वो अभी मर जाएं. So it's a difficult situation in that scenario. Okay, to come the time period during which we are coming on to a decision with the family. So in that particular time, should we continue the transfusions?
This is actually the fact. So we have to accept the fact that she is going to die, and so we can't deny it. So I think perhaps if Dr. Junaid or Dr. Atif Saleem is online, if they can add something.
So the scenario we have presented is you can take it in any.
Doctor.
Can you hear me? Can you hear me? Can you hear me? Can you hear me? आपको आवाज आ रही है मेरी?
जी अब आ रही है.
जी आ रही है.
Okay, so I mean ये scenario तो आप hematology cancer के अलावा भी कहीं पे भी डाल सकते हैं कि एक patient है जिसने अपना power of attorney अपने किसी भी बंदे को दिया है, relative को, ठीक है ना, या दोस्त को या जिसको भी, और power of attorney उसके पास है और वो उसकी सोच आपको rational नहीं लग रही. So it's a very very difficult and thin line कि आप ये कहें for example कि ऑटोनॉमी की या जो सारे हमारे एथिक्स की सारी चीज़ें उनको उनके फार्मूला या जो भी उसको अप्लाई करें यहाँ पे, तो कहेंगे नहीं जी हम, क्योंकि जो पावर ऑफ अटर्नी वाला बंदा या बेटा ये कह रहा है कि कीप ट्रांसफ्यूजिंग या कीप ट्रीटिंग या कीप डूइंग समथिंग व्हाटएवर ही और शी इज डिमांडिंग, और आप कहते हैं कि नहीं जी मैं जो है वो अब ट्रांसफ्यूज मजीद नहीं कर सकता, क्योंकि अगर इसको ट्रांसफ्यूजन की वजह से भी नुकसान हो सकते हैं। मुझे इस सवाल आता है जहन में कि अगर फर्ज करें हमने ट्रांसफ्यूजन बंद की एंड द पेशेंट पास्ड अवे, जो उसका नेचुरल कोर्स था, तो फिर वो कॉन्सेप्ट कहाँ चला गया जहाँ पे हम आखिरी वक्तों में ये कहते हैं कि हम सिर्फ पेशेंट को ट्रीट नहीं करते, फैमिली को भी ट्रीट करते हैं। ठीक है ना, बहुत दफ़ा फैमिली ऐसी बातें करती है, हमसे कहती है कि फ्लूइड चला दो, मैं नहीं चाहती कि मेरी माँ या वालिद साहब या वटेवर भूखा या प्यासा उसका इंतकाल हो। हम उसे समझाते हैं, बताते हैं कि फ्लूइड मे नॉट हैव एनी रोल इन दिस, तो यहाँ तक तो हम मुतमईन होते हैं खुद भी चलाने में। हम कहते हैं कि यार चलो चला दो, कम से कम नुकसान नहीं पहुंचा रहा। ठीक है ना, लेकिन आप जो सिनेरियो बता रही हैं उसमें आपको अब अपने नुकसान भी नजर आना शुरू हो रहे हैं ना। प्रॉब्लम वहीं आके खड़ा हो जाएगा कि अगर आपके ट्रांसफ्यूजन या ट्रीटमेंट को बंद करने के बाद नेचुरल कोर्स से पेशेंट जाता है, तो फैमिली तो सारी जिंदगी जो है ना अपने आप को और आपको ना माफ नहीं करेगी। हम तो जाके सो जाते हैं, वी विल से कि यार वी डोंट केयर, टू सम एक्सटेंट वी ट्राइड आवर बेस्ट, वी वेंट टू द लास्ट, हमने काउंसलिंग कर दी, हमने सेकंड ओपिनियन थर्ड ओपिनियंस ले लिए, लेकिन हम वो कॉन्सेप्ट भी तो हमेशा इस्तेमाल करते हैं या उसको अप्लाई करते हैं रादर, जब हम कहते हैं कि वी नीड टू ट्रीट द फैमिली एट सम पॉइंट एज वेल। तो यू नो आई मीन, हो सकता है कि मेरे जैसे फॉर एग्जांपल हमारे पास पेशेंट आते हैं और हमें पता होता है कि अब ये एस्पिरेट कर रहे हैं, और लेकिन फैमिली मेंबर एक आता है और कहता है कि मैं जमजम लेकर आया हूँ, ठीक है ना, तो मैं पिलाना चाहता हूँ। हम उसे सारा समझा देते हैं, बता देते हैं, और फिर हमसे कहते हैं कि यार बिठा के जगा के थोड़ा सा सिप दे सकते हो अगर तुम्हें देना है। और क्या वो जमजम का सिप कॉजेज द लास्ट एस्पिरेशन? आई मीन आई डोंट नो, आई थिंक मेरे लिए या हमारे लिए ये ज़्यादा ज़रूरी होता है कि वो जो प्रोसेस जो है ना वो अपनी पूरी स्मूथनेस के साथ पूरा हो जाए। जिस स्मूथनेस में या जिस कॉन्सेप्ट में गुड डेथ के कॉन्सेप्ट में फैमिली को ट्रीट करना भी शामिल होगा, है ना। तो आई थिंक देयर इज नो एंड टू समझाना एंड कीप काउंसलिंग, एंड इट इज वेरी फ्रस्ट्रेटिंग विद व्हाट यू आर सेइंग। We've been to those scenarios, but we sometimes just keep doing things just for the sake of what the family wants. So एक पर्सपेक्टिव तो ये है, और इसको हम प्रैक्टिस भी करते हैं। और जाहिर है एक पर्सपेक्टिव वो है जिसमें कहते हैं यार बस हो गया बहुत, मैं जा रहा हूँ, तुम देख लेना यार। फिर वो you know what the results are usually.
Okay. Thank you, Dr. Junaid. So the last question is that as the son was exhausted by all the resources he had, and while the family was making a decision, was it right to utilize scarce resource of a blood bank in a patient who had no hope for cure? जैसे डॉक्टर जुनैद कह रहे थे कि फैमिली के लिए we should continue transfusion कह रहे हैं, तो is it worth it to transfuse a person from our resources who has no hope for cure rather than a patient who is on active treatment, who could be treated?
No, I won't expand on it, but I have voiced my thoughts before. I think we just need to sit down with the family, make it more rational. You have your second and third opinions there already, and medical legally you should be covered, even if he has lasting power attorney or whatever sort of power attorney he has or she has. And if you have two senior physicians agreeing on something that is not in best interest, perhaps with the scarce resources, you need to draw a line somewhere.
Thank you, Dr.
I have a question here.
Mr. William.
So despite all all the strategies you are doing and family is not agree to discontinue the sport. Is there any other thing that we can do? Like there is a hospital ethics committee and somewhere else we can discuss the case that how and what we have to do.
Ultimately, the case was referred to the ethics committee because two separate consultants were taken on board, and their decision was to stop the treatment, to stop the transfusions, but the son was not on that agreement. And then the case was forwarded to the hospital ethics committee, and then they took the case from there, and ultimately then the patient expired due to her natural course of disease. And but we didn't, but till the ethics committee came to a decision, we continue to transfuse. So that's what I said in the start, that we are in East. So here family has a very high impact on the patient's treatment and everything. So thank you very much. Is there any questions? Are there any questions?
If there aren't any questions, then we'll move on to the next talk. Thank you, Dr. Rida Mansoor. Thank you very much.
Assalamu alaikum. Can you hear me?
Now, Dr.
Hello.
Atif Bakar from Khan University.
Hello. Hello.
So he would be talking on seizures.
Hello. Can you hear me?
Yes, we can.
Okay. My name is Dr. Samia Kazmi, and I'm from the Internal Medicine Department at the Indus Hospital. I was just...
Go ahead, Dr. Samia Kazmi, we can hear you.
Okay, great. So I would like to ask, what was the age of the son who was making decisions on behalf of his mother? What was his age?
I was told he was 28-year-old.
So he is fairly younger. He's a young chap. So I think that sometimes being direct with the caregiver helps to understand their fears. And definitely this young caregiver was fearful of his mother's death. Sometimes counseling about embracing death and the notion of good death plays a very pivotal role. I have observed that we don't talk about a good death often in our counseling sessions. And I feel like embracing death is an important part of the counseling skill that one should work on and brush it up. The choice of words are very important here. Also, the point made by Dr. Rida Mansoor, if it's what we're going to do, is it cruel? I mean, not transfusing the patient. Is this a cruel methodology on our part? No, I don't think so. I think that as a physician, as a healthcare provider, we're supposed to protect the sanctity of life. And we're also supposed to give the idea or promote the notion of a good death. I mean, when I am hearing this case, I'm assuming that this is a very young guy who's making really important decisions on behalf of his mother, and he is extremely fearful of a death that is about to come soon. So definitely sitting down with him, hearing his fears and coming up with a rational answer, coming down to his level might have helped in this scenario. And definitely I would also like if the psychosocial team would have been present on this forum, whoever counseled this guy. I mean, if they could tell about the psychosocial sessions that they had with him, what were his responses and what were his fears and expectations of treatment, I think that would have helped. Thank you.
Dr. Samia, we do have an ethics committee that includes the psychosocial team. So Just going to cut short here as we have got two more presentations and we are nearly running out of time. So I'll move on to the next presentation that's going to be by Dr. Atif Saleem on seizures.
Assalamu alaikum. Dr. Atif, can you hear me?
We can.
Do you want a live presentation or are you going to use the recordings that I sent you?
Oh, we are trying to, we're going to play the recorded presentation.
Okay, thank you. I'm going to be presenting a case on status epilepticus and its management in the home-based setting. So I'm presenting a case of a 44-year-old housewife. She had refractory diffuse large B-cell lymphoma. She'd undergone multiple lines of chemoimmunotherapy with disease progression, and unfortunately, she was deemed not to be a candidate for further oncological treatment. She had developed multiple brain mets with surrounding vasogenic cerebral edema, mass effect, and a midline shift. The patient and family were offered palliative radiotherapy for the brain mets, but they declined further disease-directed treatment, and they wanted to pursue homeopathy instead. The patient was then lost to follow-up for about 5 months, and then she presented to our ER with generalized tonic-clonic seizures. She was loaded with phenytoin, but the seizure activity continued the following day, and then neurology was taken on board, and they added levetiracetam for her seizures to be controlled. Dexamethasone was also added, and she was discharged home with home-based palliative care services a day later. The patient, she lives in an apartment complex on the 8th floor, and she doesn't have elevator access. So the family essentially have to take her on a stretcher up, and if they have to bring her back to the hospital, they would have to do the same. So they wish to keep her on supportive care only at home and not to be re-hospitalized again. On discharge, the medications that we had prescribed was dexamethasone twice a day, levetiracetam twice a day, phenytoin at bedtime, omeprazole for GI prophylaxis, and for breakthrough seizures, we had given her clonazepam 0.25% as oral drops for breakthrough seizures. And then a week later, she started to seize again at home. And the breakthrough seizures would occur approximately 4 to 5 times a day. It would last anywhere between 10 to 30 seconds. And then the seizures would abort with rescue doses of the clonazepam drops. Her phenytoin levels were drawn at home, and they were within therapeutic range. Her levetiracetam dose was escalated to a maximum of 2.5 grams per day, but she continued to experience breakthrough seizures. And then lacosamide twice a day was added, and she remained seizure-free for about 3 days before the seizures started to happen again. At that point, the dexamethasone dose was increased, and lacosamide dose was also maximized, but her seizures only aborted for about a week, and then they started to happen again. That's approximately 7th day of this intervention that she went into status epilepticus. And the clonazepam drops, they could just not be administered because the patient had clenched her teeth and her mouth could not be opened. So at that point, our home-based team was mobilized, and a diazepam enema was compounded in our pharmacy, and then that was brought to the patient's home, and she was administered an enema. The seizures stopped for about 30 minutes, but then they recurred. So we got another enema at home, but the same unfortunately happened. So at that point, then a midazolam intranasal spray that was compounded, and we administered about 3 doses at home. Her seizures would abort for about an hour, but then it would start to happen again. And finally, when we we exhausted all of the options that we could administer at home. The patient was brought to the emergency department where she received intravenous diazepam, and valproic acid was added as the fourth anti-epileptic to her regimen. And over the course of the next 24 hours, her seizure activity, unfortunately, could still not be controlled effectively. Various combinations anti-epileptics, including lamotrigine, carbamazepine, they were all trialed, but to no avail. Despite receiving diazepam intravenously every 4 to 6 hours, her convulsions could not be controlled. And additionally, she started to develop multi-organ failure. Her urine output dropped and she became anuric. Blood pressure started to drop. Her oxygen saturations also decreased. So then we had a very detailed discussion with the family members, and they were of the opinion that they just wanted to keep her comfortable. They were just traumatized by the persistent seizures that she was having. So palliative sedation was offered, and the family agreed. So we started her on a continuous infusion of midazolam, and her epileptic activity ceased. And unfortunately, 12 hours later, she passed away in the hospital, but she passed away comfortable and seizure-free. So the challenges that we had and the questions that come to our mind is, when we're dealing with home-based management of seizures, what are the potential non-oral routes of medication delivery that could be considered for immediate rescue abortive therapy? And then in the absence of a functional IV or a subcutaneous route at home, how can we manage breakthrough seizures effectively? And then the third question, and this is not so much about the home management, but actually even in the institutional setting, how can we manage status epilepticus that is refractory to the use of intravenous benzodiazepine? And I shared with you, we had given this patient diazepam every 4 to 6 hours, but despite doing that intravenously, she continued to seize. So the mainstay of treatment is still the use of diazepam rectal enemas. These are not commercially available in Pakistan, but we're fortunate enough to have a compounding pharmacy on site, and they were able to formulate the diazepam rectal enema for us. It's usually given as a stat dose or on an as-needed basis. The recommended guidelines say that about 10 milligrams of a rectal enema should be given, and it can be repeated every 15 to 30 minutes to a maximum of 20 to 30 milligrams. The onset of action is between 5 to 10 minutes, and then the duration of action usually between 30 minutes to 2 hours after rectal administration. Once the initial seizure is controlled, it's recommended that a regular basis diazepam 20 milligram enema is given on a scheduled daily basis. Now, there are other benzodiazepines that are also available that could potentially be given through the rectal route, including clonazepam, lorazepam, and midazolam, but unfortunately, they take longer to reach peak serum levels. In addition to the benzodiazepines, phenobarbital, carbamazepine, valproic acid, lamotrigine, they can all be given rectally. Now, they're not available as enemas, but basically what we can do is we can just crush the tablets and we can mix them into a solution, and then we can administer the solution rectally through an enema. Generally, it's recommended that carbamazepine should be administered in smaller doses 6 to 8 times a day. And with lamotrigine, unfortunately, the rectal absorption, while it's there, it is erratic. There is unfortunately no available data about using levetiracetam through the rectal route. Newer medication treatments that are coming in and now are becoming standard of practice are midazolam, either through the buccal or sublingual route. The dose is 0.2 milligrams per kg. It's used as a spray in the mouth if the patient is conscious, but if the patient is unconscious and they have clenched their teeth or mouth opening is difficult, then this might not be a route that we would have to use. The general dose is 5 to 10 milligrams. It can be repeated after 15 minutes for a total of 3 doses. And along those same lines, if a patient cannot be given oral, buccal, or sublingual midazolam, then it can also be prepared as an intranasal spray. Same dose, 0.2 milligrams per kg. It does have a quick onset of action, usually within 4 to 8 minutes, and a time to maximal concentration is about 15 to 30 minutes. And then the last that I wanted to share with you is the parenteral routes of anti-epileptics and what we could use to manage status epilepticus. Generally, the recommended medication is either midazolam or lorazepam in a continuous infusion. Because lorazepam in the intravenous route is not readily available in Pakistan, often our go-to medicine is either a barbiturate or it is a midazolam in a continuous infusion for palliative sedation. So with that, I come to the conclusion of my case. Thank you very much.
Thank you, Dr. Atif Saleem. Our last presentation is going to be on total pain. As we are going to open that presentation, if audience has any question, regarding seizures? Mind you, in palliative medicine, it is very difficult to control the seizures because the disease is very advanced. The patient comes in at very end stage. Medication options are very limited. So we do have to consider palliative sedation. So that was the thing mentioned by Dr. Atif. So our last presentation is going to be on total pain. So whenever we talk about pain, it's total pain. So we try to address not only the physical, but the social, psycho, and spiritual aspect of the pain. So over to Dr. Atif Saleem for total pain presentation.
Good afternoon and assalamu alaikum. My name is Atif Saleem, and today I'm going to be presenting a case on total pain and the multidimensional management that is required. So we've got a 55-year-old engineer and the head of the household who was being treated for metastatic carcinoma of unknown primary. He'd undergone multiple lines of cancer treatment, but the disease continued to progress. He was referred to us for best supportive care, particularly our home-based palliative care team who was looking after this gentleman. He had multiple hepatic and pancreatic lesions that caused him severe and often intractable pain in the right upper quadrant. The pain would radiate to the back. It was continuous, dull, aching in nature. He scored the pain as a 9 out of 10 in severity. It was worsened with oral food intake. It was relieved mildly with the use of topical analgesic balm and a heating pad over his abdomen. His performance status was declining. His ECOG at the time of initial presentation was 3. He required the assistance of 2 family members in order to be ambulated to the bathroom. He was no longer able to carry on with his work and was on medical leave from his job. However, he worried that he will be laid off if he did not rejoin back soon. He lived with his wife and adult 4 children. 2 of his sons are still in university. One of them was unemployed and the eldest had just started an entry-level job. The patient considered himself to be very religiously inclined. He tried to engage in prayers 5 times a day, but was finding it difficult to do so now that his disease was progressing. He feels saddened by his current health and deteriorating functional status. He often has crying spells. He's experiencing insomnia and lies awake throughout the night, preoccupied by racing thoughts in his mind. His family members complain that he is irritable most of the day and has occasional anger outbursts. His oral intake has significantly reduced in the preceding 6 weeks. He lost about 7 kg during this time. He feels profoundly weak, lethargic, and fatigued. He no longer desires to watch religious sermons on YouTube, which he would previously do on a daily basis. So the medications that our physician, when he visited them at home, he started tramadol 3 times a day, paracetamol 3 times a day, pregabalin at bedtime, an NSAID ibuprofen twice a day, a PPI for GI prophylaxis. And then he started a low dose of sertraline to address the patient's symptoms. And then after these medications were instituted, the pain control significantly improved in the following days. In fact, the patient's appetite and sleep also noticeably improved in the 2 weeks after beginning the aforementioned medications. However, his debility and deconditioning continued to worsen, and the ambulation to the bathroom became an arduous task for him. And he was now having to use a bedside commode, but because he just couldn't go to the bathroom anymore. A week later, he suddenly lost control of both bowel and bladder. The strength in his lower extremities had worsened to the point where he was essentially completely bedbound, couldn't even sit in the bedside commode anymore. And then during the home visit, the palliative care physician noted that the patient had 0/5 strength on the left side, 1/5 strength on the right lower extremity, a saddle paresthesias, and an absent anal toe. So suspecting that the patient had developed cord compression, the physician had recommended starting dexamethasone, and he advised an MRI of the spine, which the patient promptly declined. The family had informed the physician during that visit that the patient has now become socially withdrawn. He no longer speaks to his family. He just remains quiet completely, staring at the ceiling all day. So then the physician privately, with the patient alone, with no family members present, he started questioning the patient, and the patient opened up and he confided that he feels helpless and hopeless. He feels that he is a burden on his wife and children, and shares that his family would be better off if he was dead. He was the breadwinner of the family, but now he sees no purpose in life. Upon further questioning, the patient admits that he has stopped his prayers and worship. He questions, why has God forsaken him, especially since he's been so devout to religion all of his life. The patient requests the doctor not to prescribe any additional medications because the intensity of pain, as per the patient, it has not improved, even though on the objective assessment by the physician and the reports by the family members as well, the patient did not appear to be in the same amount of agonizing distress that he was on the initial presentation, where he was just moaning, groaning, he was restless, he was agitated, he was in a fetal position at that point. Yet the patient did not want to take any more medications. So the challenges that come with the management, the multidimensional management of total pain, and the questions that were coming up for the physician who was caring for the patient at home is, why is the patient still complaining of unrelenting pain when on the objective assessment, it seems that his physical pain is very well controlled? And then the second question was, how could the patient's psychosocial symptoms and the behavioral symptoms, how could they be improved? Because it was getting more and more difficult and challenging for the physician alone to address this. And then the third question was, what would be the best approach to address the spiritual and existential crisis that the patient was experiencing at that time? And it's very important for us to understand the concept of total pain, because the fact of the matter is pain is a multidimensional symptom, and it compromises the quality of life for many patients with serious illnesses. So we, as clinicians who are taking care of patients who have serious and life-limiting conditions, we need to understand the concept of total pain and its dimensions. That's a basic requisite for any provider who is dealing with patients who require palliative care. The concept of total pain, as many of us are already familiar with it, it came directly from Dame Cicely Saunders, the founder of our modern day hospice movement. She recognized this very early on. In fact, she coined the term of total pain. And what she was trying to describe was the physical, the psychological, the social, and the spiritual components that were interacting upon one another. And clinicians, we often just focus on the physical aspects of pain and the effect that the life-limiting illness is having on the spiritual, the social, or the psychological component that often gets overlooked. And because of that, treatable suffering, unfortunately, is not treated. It gets missed. Or sometimes what we'll do is we will over-medicate the patient, thinking that these are manifestations of physical pain. So in the next few slides, I wanted to kind of share with you the four domains: the physical, the psychological, the spiritual, and the social aspects of suffering. And you can kind of very easily understand that our patient was experiencing the same symptoms as well in the physical domain and the psychological domain, and then also in the social and the spiritual domain, the same symptoms that he was exhibiting as well. The total pain experience is something that we as palliative care clinicians, we need to be very cognizant about. We need to understand the interaction that happens when we're dealing with patients who have a complex total pain. They're feeling a loss of hope. They're having these spiritual and existential crises. The physical pain is just one category that needs attention, but often the spiritual, the psychological, the social pain will compound the intensity of the physical pain. And then as the suffering intensified, the family member's sense of helplessness, it might just compel them not to visit the patient that frequently, which was again happening in this patient. And this will lead to an increase in the physical pain, an exacerbation of the physical pain, because the patient's perception, they're getting a sense of abandonment from their family members who just don't wish to visit the patient more frequently. And clinicians, they cannot fully care for patients with life-limiting conditions without assessing all four domains of total pain. So it's very important, very vital for us to be able to do that. Now, how can we go ahead and how can we do that in terms of the evaluation and the management strategies for total pain? Well, the most important, single most important thing that we could do is listen to our patient's illness, listen to their narrative, and try to be unhurried and try to give them the presence, give them active listening, and try to develop a therapeutic presence with them, because that is what's going to foster the assessment of the other domains. Dying patients, we know, commonly they yearn for love, they yearn for touch, for communication. And it's not just the pharmacotherapies and the interventional-based analgesics, but sitting, listening, holding hands with the patient, that will enable us to provide the necessary care and addressing total pain comprehensively. So with that, I come to the conclusion of my case presentation. Thank you very much.
Thank you, Dr. Atif Saleem. That was lovely. If we have any questions from the audience regarding seizures and total pain. It's complete silence. Any question? I find it really difficult to manage the social aspect of the pain. So physical, we have got medications. For the psychology, we can take help from our psychology colleagues and from the psychiatrist, and we have got medications as well. So we tend to support the families, the patients. As far as the spiritual aspect, fortunately, we are in part of the world where we have got the religion support. But when it comes to dealing with the social aspect of the pain, it's very difficult. So, so I want to have the thoughts from Dr. Atif Saleem on this.
Thank you, Dr. Atif. Can you hear me?
Perhaps.
Can you hear me, Dr. Atif?
Yes, we can.
Dr. Atif, my sentiments exactly what you're feeling is what we feel as well, and it causes us a lot of distress. Unlike in the West, where social worker is a recognized subspecialty, and there are established schools on social work because they do a tremendous job. They mobilize the resources that are community-based. And in Pakistan, unfortunately, it's not just that we don't recognize the specialty. In Pakistan, the other problem is that we don't have community-based resources that could be mobilized. Uh, um, there are numerous challenges that unfortunately we encounter, especially in the social domain. And then often what we have to do as a last resort is either explore possibilities of contacting NGOs and see if they can help out, contacting volunteers and utilizing their services depending on what the social needs are. But the last and most important, and something that I consider a strength in our part of the world, is the extended family, and trying to draw off of them and utilizing them for the necessary support that is required in order to provide the best end of life care for our patients. Thank you.
Thank you very much, Dr. Atif Saleem. So we are near the end of the session, and so we have a question from Ms. Rehana Elahi. So as we are going to move the mic, so let me just remind you from the first session, we missed one of the presentations. What we are going to do, we are going to upload that presentation. So we would request if you could go through that, because it was very important from the palliative training program. So it was by Dr. Atif Saleem, and it was on establishing palliative oncology tumor board and their role in postgraduate training. So please do have a look. So we have a question from Ms. Rehana Elahi.
Assalamu alaikum. This is Rehana Elahi, Director of Nursing here. Since many years I'm working in oncology setup. Currently I'm in administration, and still palliative care and all these things are very near to our practice in nursing. I actually want to would like you to give us your expert opinion, people on the other side of the table, your physician and nurses, when we are unable to manage patient pain, when we are unable to manage the total pain, psychological, spiritual, unfinished business, all that which is happening to our patient. So how should we be able to manage our frustration? I won't say pain. It is a pain that we are unable to manage pain. Our frustration or our dissatisfaction, please.
Thank you so much for that very important question. Maybe not pain, but the word that I would use is distress. It causes us a lot of moral distress. On the other side, people forget hum bhi insaan hai. And the emotional baggage that comes with the specialty of palliative medicine, no one can understand that unless you're actually practicing in the subspecialty. On day one, when we meet with the patient and the family members for the first time, हमें उसी वक्त पता होता है कि our patients unfortunately are not going to survive. And it takes a huge toll on all of us as healthcare providers, nurses, and physicians, because unlike in other specialties, if I use oncology as an example, at least you have some success. You have some measure of patients who will be cured. And that is enough to make you feel comfortable and want you to continue to do what you're doing. In our subspecialty, unfortunately, it's not that case. So there is a phenomena that is often called second victim. And the second victim in this, unfortunately, is us, the healthcare providers. हमें नहीं कोई पूछता कि जो है हम पे क्या गुजरती है. In fact, we will get some comments, nasty comments, I would say, sometimes taunts from others, from our colleagues, कि मुझे नहीं पता आप लोग कैसे करते हो, मैं तो कभी जिंदगी में ये काम नहीं कर सकता या कर सकती, और तुम्हें रात को नींद कैसे आती है. And these are the kind of comments that are extremely painful, very distressing to all of us, because the reality is we know that this is very hard work. And at the same time, we know that not everyone has the expertise to provide this level of care. अगर हम नहीं करेंगे तो कौन करेगा? So even though when I'm meeting with a patient who's actively dying and it's having a tremendous effect on all of us, I have to often bottle up my emotions because I have to go see the next patient and the next patient after that and the patient the following day. And I'm not trying to say that we keep these emotions bottled up, because what we need to do is we need to vent these emotions, and we need to vent them in a constructive way. And we do that. We have team building exercises where all of us get together, my interdisciplinary team, and we'll just sit down and we'll cry on each other's shoulders, and we'll share the emotion, the grief that we are experiencing as healthcare providers. And it is cathartic. It is very constructive. It is positive, because once we get all of those emotions out of our body, it gives us that strength to be able to go and see our next patients the following day. The concept of compassion fatigue, which is very important. Again, we don't talk about that, is think of your body as a vessel. And as a vessel, there's only a finite amount of compassion that you can give. And we are asked to give empathy and compassion to every single one of our patients and family members. And you give, and you give, and you give. And at some point in time, the vessel is going to become empty, and you're going to run out of compassion. So in order to avoid compassion fatigue, we need to be able to work on ourselves, reading a good book, spending time with our family members, spending time with our friends, watching a movie, listening to music, anything that gives our life meaning, purpose. We need to do that in order to rejuvenate our strength so that we can muster the strength to be able to do this the following days. So I hope that answers your question. Thank you.
Thank you very much, Dr. Atif. So this brings to my mind that probably we are going to make this last discussion that we had as a theme for the next year's palliative medicine session. I thank you all for joining. I'm very, very thankful to all the presenters, including Dr. Fiona Rawlinson, Dr. Aoife Gleason, Dr. Seema Rajesh Rao, Dr. Harun Hafiz, Dr. Atif Saleem, Dr. Junaid Patel, and Dr. Reda Mansoor. I thank you all. Thank you.